Good afternoon. Welcome to the March 11, 2020 meeting of the Health Policy Commission. I'm Marty Cohen, the Vice Chair of the Commission, sitting in for our Chairman, Stuart Altman, who is joining us today via teleconference. This is a special meeting of the Commission as it is held jointly with the Legislative Committee on Healthcare Financing for the purpose of hearing public testimony on the establishment of the Commonwealth's healthcare cost growth benchmark for fiscal year 2021. I would also like to, in addition to Chairman Altman, joining us on the phone are Commissioner Rick Lord, Commissioner Ron Mastrogiovanni, Cassandra Rhoda representing Secretary Heffernan, I believe Lauren Peters representing Secretary Sutters, and also joining me here, Tim Foley, David Cutler, Don Berwick, and Barbara Blakely. I would like to also welcome our legislators. We have Vice Chair Cullinane with us from the House, who is the Vice Chair of the Healthcare Financing Committee. And we expect Senator Cindy Friedman, the Chair of the committee, to join us as well. I want to reiterate that the commissioners and legislators calling in should feel free to participate in the discussion session today. You will be unmuted throughout the conversation, so speak up. Please note that this hearing is also being live streamed on the Health Policy Commission's YouTube channel. There will be no actual votes taken at today's hearing. But in light of the governor's declaration of an emergency related to COVID-19, we thought that using all of our virtual tools was important. And while I know something about health policy, I know little about those virtual tools. So I'll turn it over to Executive Director Seltz to say more about the meeting today.
Great. Thank you and good afternoon, everyone. Thank you for being here. Thank you, commissioners. Before we begin the hearing and want to turn it over to the Vice Chair for some opening remarks and to be able to introduce the esteemed members, I do want to just first acknowledge and welcome the members of the Joint Committee who are here with us today and some who may be participating remotely. Thank you for your flexibility and partnership in the change in location for today's hearing. We were very excited to hold this hearing at the State House as we did last year, but obviously due to some public health concerns and consistent with the governor's guidance, we really wanted to move it here to the HPC office primarily and solely to just be able to have the virtual options available for the public. So thank you for your flexibility in this matter. I'd like to also welcome the many of you who are viewing through our live webcast. Thank you for your continued engagement in the HPC's work, and we're happy to be able to provide this safe and convenient virtual option. As you noted, Vice Chair, in addition to the webcast, we also have a webinar running for the commissioners, some other Joint Committee members, so that they can engage in the dialogue here today. And our esteemed external guest, Zach Cooper, from Yale University, who will be presenting later, will be presenting remotely through that option. Since we're using multiple different technology solutions today and with attendees in many different locations, I just ask for your patience and understanding today if we do need to pause the hearing at any point to deal with some technology issues, so thank you. Finally, in the light of transparency, in the interest of transparency, I'd like to provide the board with a quick update on the precautions that we here at the HPC are taking to stay healthy and to prevent or to mitigate community spread of coronavirus. So I'm going to ask Deputy Executive Director Colleen Elsmeyer just to give a brief update on what we're doing here at the HPC.
Sure. Thanks, David. So as David said, I'm just here to give an update on the precautions the HPC is taking to help both mitigate the impact of the coronavirus outbreak and protect the health and safety of our staff and the public with whom we interact on a daily basis. Since the beginning of the outbreak, we've been closely adhering to the DPH and the CDC guidance We've also been in close consultation with Chairman Altman, the administration, and other leadership from the independent and quasi-state agencies, especially the healthcare agencies. We've also been in close communication with our building management here at 50 Milk Street. Although we are an independent state agency, we have fully adopted the governor's guidance for executive branch agencies on all work-related travel, conferences, and discretionary gatherings. Those are all prohibited from here on out until further notice. We've also elected to postpone all meetings with providers and caregivers, all on-site meetings. And we are moving as many external meetings to remote and virtual participation as possible. Starting today for our staff, we're expanding our remote work program to include all of those in the high-risk population and all of those who are caregivers for those in the high-risk population. And we're strongly considering extending remote work access across the board for all HPC staff. We have been expanding over the past 3 weeks our IT capabilities to be able to accommodate the potential for increased telecommuting as well. David and I are planning to continually reassess the situation. We're pursuing a high level of transparency with our staff and with our board. These are, very difficult decisions that businesses all over the Commonwealth and all over the country are making, but we think they're sensible precautions, and we want to particularly thank Secretary Sutters and the governor for their leadership in this matter. Our priority is to be as prepared as possible while protecting the health and safety of our staff, and as I said, the public with whom we interact on a continuing basis. We plan to continue the important work of the HPC, so that won't stop. And I just wanted to say, if any of our stakeholders or public or members of the board have any questions at all, please just reach out to me directly, and I'm happy to answer any questions. So, thanks so much. Back to you, David.
Great. Thank you, Colleen. And obviously the context that we're holding this hearing today is a unique one, to say the least. And I'd also like to publicly acknowledge the leadership of Governor Baker, Secretary Sutters, Commissioner Burrell, but also Senate President Spilka and Speaker DeLeo for their leadership. We're grateful, really, to have such strong, competent, and rational political leaders here in Massachusetts. And I know that Secretary Sutters did want to be here today in particular, and Secretary Heffernan, but as imagined, other priorities today. But the work of government continues, and the mission of the HPC and our collective goal in the Commonwealth of advancing a high-performing, accessible, and affordable healthcare system is as urgent today as ever. And so the important purpose of today's hearing is to collect data and public testimony on our state's performance against the healthcare cost growth benchmark, a unique annual spending target, and we're happy to host this public forum and to do so in a transparent and open process. So with that, Vice Chair Cohen, I'll turn it back over to you for some further opening remarks from our colleagues from the legislature.
Thank you, David. And thank you for the work that you're doing to both protect the public and to protect the staff and folks at the HPC.
Move your microphone a little closer.
As I mentioned, this is a joint meeting with the Committee on Healthcare Finance. It gives me great pleasure. I'm thrilled with our turnout from our legislative delegation, and it gives me great pleasure to introduce Dan Cullinane, the Vice Chair of the committee, who will say a few remarks and introduce the members who are present. Dan.
Thank you very much. I appreciate it. In light of all the different technology that we're using, I'm going to be very brief so that we can, as fast as possible, dive into the substance of why we're here. I do want to thank David and Colleen and your whole team here for being able to get this meeting up and running and making sure we had available to us collectively all the technology that's at our disposal. I think that's so important as we heed the warnings of COVID-19 and the governor's direction, as well as the Speaker and Senate Presidents as well. So I just want to say that, in the history of Massachusetts, healthcare reform has always been a collaborative effort. The House continues to be a partner in that, as well as all my colleagues that have taken time to be here today are all partners in that effort and very eager to dive in today. And so I just want to leave it there say thank you to everyone that's here, to continue to use the House and our committee as a partner, and we look forward to jumping in. But before we do so, I want to give the members that have taken the time to be here today the opportunity to introduce themselves and the districts that they represent so that everyone here is aware of who they're speaking with. And I also want to extend my thanks to the healthcare financing staff. If you can put your hands up so everyone knows who you are here today. I want to thank you guys for all of your work throughout this session and getting everything ready today. And so with that, we'll dive right in, and to my left, we'll begin to my left.
I'm Christine Barber, Somerville and Medford.
Bill Driscoll, Milton and Randolph.
John Santiago, Boston.
Natalie Higgins, Leominster.
Lenny Mira, Georgetown.
Joe McGonigal, Everett.
Brian Murray, Milford, Hopedale, Mendon, and part of Medway. Matt Muratori, Plymouth.
And I think if there are any legislators on the phone, if you could just introduce yourselves in your district. All right, well, I want to thank all of the House members for being part of today's hearing, and I look forward to working with you all and diving right into the substance of today's benchmark.
Great, thank you. Okay, so to start things, I'm going to turn it back over to David, who will introduce our first presentation.
Great, thank you, and Vice Chair Cullinane, agree completely in the partnership and collaboration. Thank you for those words. So for today's hearing, what we're planning to do is first give a presentation from myself and our Director of Research and Cost Trends here at the Health Policy Commission, just detailing a little bit of reviewing the process for modifying the benchmark and what is the healthcare cost growth benchmark. We'll review some of our performance against that benchmark in recent years. And we'll also look at some national trends in healthcare spending. We'll also discuss and examine how the Health Policy Commission actually holds providers and health plans accountable to meeting the benchmark. And then finally, with a focus towards why are we doing this? Why is this work so important? We'll reflect on some of the affordability challenges and implications for healthcare for the residents of the Commonwealth. So the first part of this presentation will be David and I. We're then going to pleased to be joined by a great external expert, Zach Cooper from Yale University, who will continue to give his perspective on some trends and data. Throughout this entire presentation, we really do want to encourage you to ask questions, engage in the conversation. We'll pause along the way, but certainly for everyone on the phone and for everyone here, please feel free to ask questions and engage in the data and the topics as we move through this. After the two presentations, we'll then open it up for some public testimony. We do have a number of people signed up to testify, both in person and virtually, at the end of today's presentation. So to dive right in, and I think all of you have these presentations in front of you, we first wanted to just start with a little bit of background. What is the healthcare cost growth benchmark, and how is it set on an annual basis? So in 2012, Massachusetts passed a significant comprehensive healthcare cost containment legislation, and a true partnership between the legislature and the administration, and I think reflective of Massachusetts' long history as being a national leader on healthcare reforms. And this bold new effort was reflecting the troubling fact that high and rising healthcare costs in the Commonwealth were placing real pressures, not just on government, but on employers and businesses in the Commonwealth, especially small businesses, a backbone of our economy, but also on families and individuals who are seeing whatever revenue or whatever wage growth that they were receiving being completely subsumed by rising healthcare costs. And so the legislature passed comprehensive legislation to try to bend the healthcare cost curve in 2012, and the central organizing principle of this legislation is the establishment of a healthcare cost growth benchmark, a target by which we would seek to moderate the growth in healthcare spending over time. This is really the kind of innovation of this particular piece of legislation, and as I'll talk about later, many other states are now adopting similar types of principles and proposals. But I would reflect also on the vision here on this slide, which is to say this isn't just about cost containment. It is also about how we can improve the quality of healthcare, the access to care, the innovation of care, and really being able to have a high-performing healthcare system that truly improves the health of our communities, delivers great quality care, reduces disparities and inequities for all the people of the Commonwealth. We think that we can achieve all of these goals, that we can have a high-performing healthcare system that is more affordable and accessible to those who need it. A word about the healthcare cost growth benchmark on the next slide. So in law, this target is tied to the long-term economic growth rate of the state. And the concept and idea here is really that around that crowding out effect, which is to say healthcare should continue to grow. This is a growth target, but that it should grow more consistent with how everything else in the economy is growing. And so this was first set in law at 3.6%. And is updated annually in a process by which the legislature and the administration, through the joint consensus revenue process, reevaluate that long-term economic growth rate. That has continued to stay at 3.6%, and for the first 5 years, that was our healthcare cost growth benchmark, and it was set in law to be equal to that long-term economic growth rate. However, after the first 5 years, the law allowed for a modification of the benchmark and actually lowered the default rate to that economic growth rate minus half a percentage point, or 3.1%. So for the last few years, we have gone through this modification process, and ultimately the HPC board has decided to keep it at the default rate of 3.1%, kind of the most aggressive rate allowed under the law. We do have a process by which we can hold individual health plans and providers accountable to that benchmark target, and that we'll talk a little bit more about that later today. But again, just as a reminder, this is total healthcare expenditure growth. So it includes both spending on the state's Medicaid program, but also commercial, employer-sponsored healthcare, Medicare spending, as well as what people pay out of pocket in the form of their copays and deductibles. And finally, the administrative costs of private health insurance. And the reason for having a kind of an all-in measure like this is to be able to truly understand and ensure that there's not unnecessary cost shifting between those different sectors, and so that we can keep track of all of the different component pieces about how healthcare spending is increasing. On the next slide, you can see kind of visually here how the law allows for some flexibility in kind of this middle 5-year period, and that's where we are today. So for the first 5 years, the board had really no flexibility in modifying the benchmark. For this next 5 years, we can, the default rate, as I said, is 3.1%, but we can modify it to any number between 3.1 and 3.6%. We have not elected to do that modification in the past 2 years, but we have that availability. And then beginning in 2023, the board has the authority to set the benchmark at any rate and is not bound by the half a percentage point, but does require this continued legislative partnership with the Joint Committee on Healthcare Financing, and something that would be an ongoing basis of having this annual review and check-in with the Joint Committee. So as part of the decision to whether or not to modify or whether to stick with the default rate of 3.1%, we hold a public hearing with the Joint Committee on Healthcare Financing. Thank you all for being here. And in this hearing, we'll consider data as well as stakeholder testimony. The board, HBC board, will not vote today on whether to modify. That will happen at the next board meeting, which is scheduled for April 1st. So we'll consider the testimony. The board will consider the testimony here today, as well as written testimony, and return at April 1st to decide whether to stick to the default rate of 3.1 or to modify it up. If the board does decide to modify it to something other than 3.1%, that does trigger an additional legislative review. In that case, the Joint Committee on Healthcare Financing must then also hold a hearing and can make recommendations basically to the general court and allows for some time where the general court may take action before the benchmark would go into effect. Again, this part of the process has not happened in past years because the HPC board has decided to stick with the default rate of 3.1%. That additional review process only happens if there's a decision to modify the benchmark upwards. So on this next slide, you can kind of just see the timeline here. As I mentioned, at the next April 1st board meeting is when the board will consider whether to modify. And on the next slide here, you can see that this is part of an annual process. And so I won't walk through all the different parts of this wheel other than to say we're at stage number 1 of this annual process. And then in partnership with our sister agency, the Center for Health Information and Analysis, we collect the data, we analyze the data. They issue a report in around September. We hold our annual cost trends hearings in October. We issue our own annual report and consider whether performance improvement plans are warranted for individual health systems or health plans. And then the cycle repeats itself at the end of the year and begins anew. So we're at the beginning of this year's cycle of the healthcare cost growth benchmark and annual review process. Finally, I mentioned this earlier, but I do want to just highlight for the Joint Committee and for the board that while we were the first state to establish this idea of a growth target, we are no longer the only state. Since Massachusetts passed this in 2012, there have now been 4 other states that have adopted similar types of kind of sustainable total healthcare spending growth targets, including some of our neighbors here in New England. And I would also note that a number of other states are actively considering establishing a similar type of model. Massachusetts, we pride ourselves on being a model for the country. Certainly we were a model in healthcare access reform in 2006. And here too, we are encouraged to see that other states are learning from our experience, adapting our ideas and principles, and we hope to be able to learn from their experience as well as we continue this evolution and adaptation of the healthcare cost growth benchmark. The law also established the Health Policy Commission. So we are an independent state agency whose job is to help monitor and to guide this effort to hit the healthcare cost growth benchmark. And we do so through a number of different tools. We have a team of researchers and data analysts who help mine the data so we truly understand where are the drivers in healthcare spending and where are those opportunities to create better efficiencies or to remove unnecessary spending. We're also convener. Like today, we work in public board meetings, but also work to convene the experts across the healthcare system to be able to try to understand those challenges and problems and come up with collective ideas for solutions. We're a partner and an investor. We've invested over $100 million into healthcare providers here in Massachusetts, mainly community hospitals who serve very complex populations and are key providers of healthcare in many of your communities. And we're proud to be able to invest in new innovative ways of delivering care. And then finally, we're a watchdog. And we act on behalf of the public, the families, the individuals, the employers who are bearing the high cost of healthcare and identify behavior or market performance that we think is perhaps inconsistent with our goals of being able to hit the healthcare cost growth benchmark. So as just a background on what the healthcare cost growth benchmark is, how it's set and modified every year, and a little bit of background on the Health Policy Commission, I'll pause there before we dive into the data part of this presentation to see if there's any questions about the benchmark or about the HPC or this process here today. Great. Having seen none, I'm going to now turn it over to David Auerbach, who is, again, our Director of Research here at the HPC, to walk through some of the data about what we know about our experience to date, where are some of the key cost drivers, and again, where do we see some pressure points in the future, and where those opportunities may be. So, turn it over to David.
Okay. Thank you, David. Good afternoon, everyone. The first section will review past and recent performance against the benchmark, and we'll break that down a few ways. First of all, this is the overall trend for the last 6 years in which performance has been recorded against the benchmark. And you can see, for example, we've been above in some years, we've been below in some years. On average, healthcare spending growth from year to year has been 3.38%. And you can see that's a little above the 3.1 where the benchmark is today, but for the last 3 years, we have been below, well, with the last year exactly meeting the 3.1% benchmark. And that's a preliminary figure. It might change when we get the data updates in September. We can break that spending down in a few ways. Here, we're breaking down performance against the benchmark by the major sector: commercial spending, Medicare, and mass health or Medicaid. And you can see in this slide, it's not that any one sector has been consistently above or below, but they all have trends kind of around the benchmark. But you'll notice that mass health has fluctuated more than the others. That's partly because enrollment changes are also in these trends. These are not per capita, but these are total spending. And mass health enrollment has fluctuated across the years. Okay. We can also break down that spending by category. For example, within the healthcare system, you can see on the bottom in those orange slices that shows how much spending is in each category, such as hospital inpatient, hospital outpatient spending, and so on. And the blue bars show spending growth. The light blue is spending growth from 2017 to 18. The dark blue bar is spending growth from 2016 to 17. And one thing of note on this chart is, for example, you can see hospital outpatient spending and pharmacy spending were both pretty high for the last 2 years, above the benchmark rate. In this chart, we're breaking down spending into the components of prices, the price you pay for a given service, and utilization, the number of services used, as well as a category of service mix. Is the intensity of those services changing? And this is a pattern averaging for the last 3 years across the 3 biggest insurers in Massachusetts. And this shows, as we show year after year, that price tends to be the dominant factor. Price growth has been about 2 to 3% per year for the 3 major payers, whereas growth in utilization of services and mix of services contributes about maybe a third to a half of spending growth. And on this next slide, we can show kind of an example of that interplay of price and utilization. This is looking at hospital inpatient spending, just in the commercial side. And in this case, for example, utilization, or the number of hospital stays paid for by commercial insurers, has dropped. That's the blue line. From 2013 to 18, it dropped from about 240,000 to 215,000 stays. But at the same time, on the orange line on top, the total spending for those stays has grown. We have not reaped the savings from moving people out of the hospital or fewer hospitalizations. And why has spending grown? It's because the amount paid per stay has grown quite a lot, from $14,500 in 2013 to $18,700 in 2018. That amounts to a 29% growth in spending per stay. So that has prevented us from achieving savings from a reduction in hospital stays. And that price growth is divided among prices for a given stay and a rising acuity of those stays, which we talked about in our cost trends report. Okay. Now we'll look at some trends of how we compare to the rest of the country. I think we've all seen this graph before. This is showing our growth rate trend per year compared to the US. Massachusetts is the orange line. And you can see since around 2009, our total growth in healthcare spending has been below the national average every year. You'll also notice that there's sort of a parallelism in those patterns. That's important to note, that some of the forces going on nationally are also going on here. For example, prescription drug spending and pricing is a national phenomenon. We also see in the commercial sector, similarly, around 2013, we switched from having higher growth to lower growth, and that's been consistent from 2013 to 2018. That's our commercial spending trend. But note here in this slide is explaining some of why, even though our commercial spending has been lower, we haven't really reaped the savings in terms of premiums where people are getting their insurance through employers. So the medical spending trend on the left is what you just saw, 12% versus 25%, but the employer premiums, part of why we've had lower spending is our individual market. The Massachusetts Health Connector has been very low spend and very low growth. Also, factored into these employer premiums, you have administrative costs, which have grown faster. So we have not really experienced a lower growth in our commercial employer premiums. As much. That's right. Okay. So what do we know about what might be coming in the future? Now we're going to show some national data. This is from CMS, the Center for Medicaid and Medicare Services, showing trends in, and again, private commercial spending as well as Medicare and Medicaid nationally. Here you see that trend in the blue. Private health spending growth year after year has been accelerating. It's been growing above the pack. And you can see that that has been in the 5, 6, 7% range lately. This is the national trend, the spending per person. And a lot of why that blue line is growing faster than the orange and yellow is prices, which are administratively set in Medicare and Medicaid, but not in the private sector.
Can I ask a quick question?
Yes, please.
So is this is the payer, this isn't the individual, it's not the policyholder, right?
Well, it is. It's really the same.
It's both, but it's
Yeah.
the insurer as well.
It's the
payer.
this is reflecting those premiums. Yes, so it is both. Yeah. Okay. And now we can turn to a slightly different data source. This is from the Alterum Institute, which uses a data source that is much more recent, up to the minute, and it's similar to the CMS data we just showed, but it gives us insight into what is going on even in 2019. And you see here that they're showing year-over-year growth in spending in 2017, 18, and 19 in the blue. And you can see in this data, 2019 growth has been even faster than 2018. So especially led by high prescription drug spending in 2019. So this is an indicator of what we might be seeing, might have already seen in 2019, although we don't have the data yet, but could be upcoming in our future of greater and greater challenges in controlling spending. And this lower slide is showing projections for the future. This is from CMS, again, and we are breaking down projected health spending from all payers into the components of prices, utilization, and age-sex mix, which is that light blue portion on the top reflecting an aging population. And the main point here this is showing is that the prices on the bottom are accounting for about half of past and future price growth. And if you keep that in mind, that suggests that if we are trying to meet a 3.1% benchmark, prices really shouldn't be growing much more than about 1.5%, because utilization is going to grow and because we're aging. And so that's roughly about the amount of price growth that we can afford if we're going to meet this benchmark.
So we'll pause there for a second, and I just kind of want to take an opportunity to have members ask questions about the data that we just presented. I guess I would kind of summarize the data that David just presented as such. We have made considerable progress and notable progress in bending the healthcare cost curve since the benchmark was established and since the HPC was established in 2012. We've been below the benchmark in most years, and on average, we've been below the benchmark. This is particularly notable when you look at what our trends were prior to that period, where we were consistently above US averages. Now we are consistently below. However, as David noted, we haven't seen as much in the form of savings truly being passed on to individuals through lower premiums or through lower deductibles or lower co-payments. And so, as we'll talk about a little bit later, there are continued real affordability challenges for small businesses, for individuals, for families in the Commonwealth. The national data that David shows, I think, is a little bit of a warning. We see that the pressure is going to be increasing in the future nationally on healthcare spending growth. And so I think part of a reflection that we have in our cost trends hearing and in our report is that there may need to be new or stronger tools in our, quote, Massachusetts toolbox if we're going to be able to continue to bend the cost curve, to be able to hold spending to a more affordable and sustainable level. And so we have made a number of recommendations to try to think about what are the right types of legislative changes that might help us be able to meet that trend in the future. But I think the national data is sobering in that regard, that the pressure will be increasing in the future.
Questions from the members?
Oh, yes. Go ahead, John.
Just on slide 14, you what actually caused that spike from 2.4% in the benchmark to go to 4.8 within a 2-year period? So I can understand it. What causes that increase?
Yeah,
That drastic increase?
Yes. So it's interesting, and I think to answer your question, there were unique things that were happening in those 2 years that caused us to go above the benchmark. So one of the reasons that we do see increased spending in those 2 years that was above the benchmark was there were technical difficulties with the Health Connector back in 2013, and the state made the decision to prioritize access, and so everyone who would have kind of signed up through the connector received temporary Medicaid coverage. And so that did increase our healthcare spending in that year. But I think there was a value judgment that access was most important and continued coverage was most important. So I think my point here is to say, even in years we go above, that's maybe not necessarily a failure if there are other kind of things of value that are driving that. And then additionally, in the other year that we went above, there was the introduction of a new therapy for hepatitis C, Sovaldi, which when it was initially introduced had a list price of over $100,000 per treatment. That alone caused a significant increase in spending in that 1 year, just the introduction of that one very high priced but effective drug. Again, I think I think reasonable people may disagree about whether that was the right price, but I think we all understand that that was a curative treatment that will provide real value and benefits for families, and individuals in the long term in terms of curing a disease. So I think the point is that looking in any individual year, there might be unique things that will drive us above or below the benchmark. And so we try to every year kind of dive deeper underneath that and say, is this what is driving that? Is this a problem? And in some cases, maybe we say, there's reasonable reasons why we might go above the benchmark in a year, and it's kind of a long-term goal.
Representative Mira.
Thank you. And just so we're clear, on slide 20, that shows that healthcare spending growth in Massachusetts has been below the national average. What about the overall per capita amount? How is Massachusetts comparing to the rest of the country in overall per capita spending?
Yeah. So the data that by which we can compare ourselves to other states is always a little bit of time delayed. This is a national data set. So the two data points I have for you is in 2009, before many of these activities started, Massachusetts had the highest per capita healthcare costs of any state in the country. I think 36% above the US average in terms of a level. That data got refreshed in 2014, and we were no longer number one. We were number two. But during that time period, actually had the fourth lowest growth rate of any state in the country. So I think the point is important and well taken. We have a high level of healthcare spending even before we talk about bending the growth curve, and that's what these are showing is growth off of a very high base. So thank you for that question.
Thanks.
I could also add that our commercial premiums are kind of, third, fourth highest in the country is another way to gauge that.
Third or fourth, thank you.
Yeah.
That's helpful.
Thank you for your helpful analysis and all the work you're doing on the cost trends. Two questions. So one, I was struck by how recently the Mass Health spending has decreased pretty significantly. And I just wanted to clarify, this, I think timing-wise, is before Mass Health had the tools to negotiate and bring pharma to the table. Is that correct? I see your staff nodding.
Yes. Yes.
So it doesn't even account for that savings?
That's right. The most recent year here is 2018.
Okay.
And
And
it
that's already
was
the-
just last summer that authority was passed into law. So that would begin to be reflective in the 2019 numbers, and then I think especially in 2020.
I would just add, it does include the beginning of the accountable care organizations under Mass Health.
That's correct. Yeah.
Right, so that was a big shift there. And then separately, I know this came up at the cost trends hearing and in the report, but I think, like most of us, really struck by, utilization, a lot of the things that we think of with healthcare being flat, and then prices really being what is growing here. So are there, I know you guys have a lot of recommendations, but key things you think we should be focusing on to address the price issue, since obviously the trends going forward are pretty frightening considering where healthcare costs are already at for affordability?
So I think there is probably not one silver bullet to address kind of the inflationary price increases. We're going to talk in a moment about how we measure and hold individual providers and health plans accountable to the benchmark, and we are recommending some changes to that process based on kind of lessons learned to be able to bring in other types of metrics like price growth. Additionally, one of our biggest and strongest recommendations is on out-of-network billing, which speaks to some of these kind of the price impact issues, as well as some proposals around restricting facility fees, which again is kind of a price inflationary mechanism for hospital licensed outpatient facilities that can charge a greater amount per service. So I don't have one silver bullet here. I think it's kind of a combination of different tools, and we can talk a little bit more about some of our recommendations.
Great, thank you.
Yeah.
Representative Martone.
Thank you very much, and thank you again for the analysis of this, very helpful. What struck me on this is Medicare and hospital spending increasing drastically. Any thoughts of why that's happening?
You want to take Medicare?
Sure. Which slide are you?
So page 15 was the Medicare.
Okay. Oh, this one? Okay. So this is all services, but the Medicare increase from 17 to 18, we don't have a great insight as to what leads to that. One thing I will note is that across this whole period, the Medicare is higher than it would be per person, because Medicare enrollment is increasing because we are aging. So you could probably take maybe 1% to 2% off of that if you went to a per capita basis. But the Medicare 2017 to 18, yeah, I'm not exactly sure. It seems to be price related, and maybe it was an adjustment that happened.
Is it related to the hospital spending as well?
Probably.
Thank you.
I mean, we did show in our latest cost trends report an increase in hospital spending, which is driven by what appear to be sicker and sicker patients. And as we dived into that, we found that part of it isn't really that the patients are sicker, but they are being coded and recorded that way. And we have a long discussion about that. And that certainly affects the Medicare hospital costs and the commercial hospital costs.
Interesting. Okay, thank you.
Yeah, Vice Chair.
Thank you. I just have a couple questions that I want to go through here. And the first is, what is the Commission's opinion on our ability to continue to meet this benchmark in the coming years if we see an economic downturn and then Mass Health enrollment increases?
I think,
David, can I?
sure.
Sorry that I'm a health economist by day, so I thought
Yeah.
I thought I would take a crack at it.
Thank you.
I think in some ways, actually, a recession makes it easier to meet the benchmark target. The reason is that the benchmark target itself doesn't decline, but as incomes fall, fewer people seek out medical care. So there would be what's called an income effect, which is just fewer people going for discretionary services and things, and so that would make it easier. On the Mass Health end, the rates that Mass Health pays tend to be lower than the rates that commercial insurance pays. So all else equal, moving an individual from a commercial policy onto Mass Health would also lower spending. So my sense is that the recession time, in some sense, is a little bit easier to meet the target, although need to be careful because that deferred care, I don't want to say it's a good thing that people are always deferring. It doesn't mean it's a good thing. It's just on the spending side, it probably means less. I apologize, David.
No,
I just
thank
had
you.
to display my day job.
Please, commissioners, jump in.
And I also wanted to ask that, it's probably given at this point that we're going to see a pretty significant spike in medical spending related to COVID-19, and just how do we see this increased spending also have an impact on the benchmark potentially? And just kind of, do we kind of have the future cost trends to be able to separate out the spending that's linked to this unusual situation versus overall spending? And, are we going to be able to have that conversation in the months and, I dare say, year ahead?
Yeah. Thank you. I think a really important question, and one that we're reflecting on. And I think it's as you said, it's so early to tell exactly how this will all play out. Obviously to date, I think the Secretary said there are 6 hospitalizations. I think all reasonable people expect that to grow. But many of the kind of the precautions that the governor is proposing is really around kind of mitigating that kind of acute spike, so that the healthcare system can continue to kind of have the capacity over time to treat people. So how does this relate to the benchmark, though, if there is increased spending? I think as was shown before and discussed before, the benchmark is not a cap. So there are years where it will exceed the benchmark. And as discussed before, there may be good and rational and reasonable and worthwhile reasons why it would. In those, and in those years and in every year, when we are holding or examining whether to hold a health plan or a provider kind of accountable for their own spending through the performance improvement plan process, we, the board, and written into our statute and in our regulation, we have to take account if that spending growth was outside of that entity's control, and take that, kind of, was this something that the entity actually had control over? And if not, then we certainly take that into account when thinking about whether a performance improvement plan or other accountability mechanisms would be warranted. And we have in the past. As I mentioned before, in that year when the new drug was introduced, spending growth was higher. There were entities that were above the benchmark. And in the process of that review, it's a back and forth, and we examine data, they show us information, and certainly they said a lot of our spending growth that year was because of drug spending, and the board, I think, took that into consideration and did not propose a performance improvement plan during that time period. So I do think that the process does allow for that type of contextual review, and certainly we would take into account any factors that are outside of kind of any one health system's control, obviously this being an example of that. I think on a really truly technical matter, the commission's decision before us today, or before the board today and on April 1st, is setting the target for 2021. We already have set the target for the current calendar year that was set a year ago at 3.1%. So in some cases, we'll see what happens in 2020. The decision is really even looking further, and there it's even much harder to predict or speculate on what the impact may be. But I don't know if other commissioners want to weigh in on this.
I just want to pick up on the vice chair's question. Will CHIA be able to break out both patient costs related to COVID-19 as well as the larger sort of personnel provider costs related to COVID-19? Do we know?
So we do understand that there are already codes in place for coronavirus testing and treatment. So I think in the claims data, we'll be able to see kind of the utilization of services and expenditures and be able to create a linkage. I think what will be harder is that kind of healthcare spending and healthcare expenditures. The costs, the kind of administrative and operational costs that may be borne by providers that is not necessarily reimbursed services, I think will be more difficult to unpack, and certainly I think will require a good deal of back and forth with the entities to try to, as they are staffing or creating other precautions. And again, don't want to speculate too much on what that may be, but just to make that distinction.
Thanks. Other questions, commissioners?
I just had one more. I apologize. This one's a little bit different. We're seeing the channels through which patients access healthcare rapidly evolving, and so there have been introduced certain disruptive elements into the market, like whether it's Amazon or Haven, and this vertical integration across traditional sectors and private equity's influence growing. So my question is, are we collecting the right data that's going to allow us to accurately analyze this different spending costs in the market? And if not, or if we need to expand that conversation, which emerging markets and new service lines do you think that as an entity we need to collect data from as we look to the future?
So I will take a stab at that, but then also open it up to others on the HPC board. I think one of the new kind of points of entry that comes to mind immediately is urgent care centers. And so that has been a growing sector that we have tracked over time. Urgent care centers can be licensed as many different types of things. They can be licensed as a physician's office, as a hospital outpatient department. And so one of our recommendations in the cost trends report, and something that's in the governor's bill, is around creating a better kind of infrastructure, regulatory infrastructure for urgent care centers, so that we can be able to better track where they are, what services they provide, what populations they serve. So that's kind of one emerging field. And as other entities come into the healthcare market space, like Amazon and Haven, again, we may want to revisit that and think about what other tools and transparency and data collection tools may be warranted or needed. Again, hard to speculate when it's unclear exactly how they're going to be entering the healthcare field, but I think I guess I would just say happy to kind of work with the committee and provide some ideas and feedback, and certainly this is an ongoing, evolving experiment and process here in Massachusetts, and part of that is how, and I think a strength of the benchmark is that it can be adaptable over time as the market changes.
Right. Thanks, David.
Other questions?
So switching gears very slightly, I do want to take the opportunity today to review with this board and with the committee a little bit more about how we actually hold entities accountable to the benchmark. So we've talked about the benchmark as a total statewide healthcare spending target, but we also look at it with regard to individual health systems and individual health plans. And so I want to review that process briefly and talk a little bit about some of the limited successes, but also some of the limitations that we've observed in this process, ending with a recommendation to the legislature. So with that, I think we're on slide 28. Thank you.
Make sure we're all paying attention.
And I'm going to turn this part of the presentation over to Kate Scarborough-Mills, who is our Director of Market Oversight and Transparency.
Great. Thank you, David, and thank you, everyone joining us either in person or remotely. So a lot of the themes that you've heard about overall performance, we've also seen play out as we've looked at individual payer and provider performance. So Chapter 224 envisioned that one of the key tools in the toolbox, if you will, for holding individual payers and providers accountable for the healthcare cost growth benchmark is what's called the Performance Improvement Plan, or PIP process, which is summarized on this slide. It's a shared process between CHIA and the HPC, and it is a little wonky, so apologies. If anyone wants me to slow down, please chime in or raise a hand. Happy to take questions throughout. The first step in this process is that CHIA is charged with referring payers and providers to the HPC for further review. So CHIA is actually required by statute to use a measure called health status adjusted total medical expense to do that analysis. So they look at any payer or provider whose growth in this measure in health status adjusted total medical expense for any contract in the case of a provider. So we're looking at individual health plan performance. So a provider's patients with, say, Blue Cross, or on the case of a plan, their performance in a book of business, so their commercially insured members versus, say, their Medicare Advantage members. CHIA looks at the health status adjusted spending for those contracts and books of business and will refer to the HPC for further review any contract with spending growth that's over the benchmark level, or any book of business with spending growth over the benchmark level, or in certain cases where the entity is large, has a baseline spending level that's high, they can refer if the growth is 85% of the benchmark. So when the benchmark was 3.6, that was 3.06, just to give you a sense of how that math works out. So because the statute requires the use of health status adjusted total medical expense as a measure, the next slide kind of goes over that measure in even more detail. But one of the key things to note about this is that because they are statutorily required to use this measure, they can only refer entities for which this measure exists. And that is, for providers, only primary care groups. So it's only talking about the spending for the primary care patients of a provider. So we're not holding, for example, individual hospitals as part of this process. Once an entity is referred to the HPC based on its spending growth on this one measure, the HPC then enters into a much more kind of robust analysis across many different years of performance and many different measures. And so we look through a number of different things, including performance across all of the contracts that a provider might have, or for a payer, all of the different books of business for a payer. We take into account things like pricing levels and trends, utilization patterns and trends, the population served, the payer mix, the product lines being offered, the size, market share of the entity, the financial condition. Really importantly, as David noted, we look at things that may have been driving spending that might be out of an entity's control. For example, when Sovaldi hit the market, we saw that that affected individual plans and providers on somewhat different timelines and tried to take that into account in our process. And we look at ongoing strategies and investments that the entity may be making to improve efficiency or reduce spending. So this approach, the HPC review, is really meant to contextualize the entity's performance across many different dimensions to determine the level of concern that we really have about an entity's spending trends. And it also allows the entity to bring forth data to us that we may not have access to that shows, for example, any mitigating factors that we should take into consideration. If after our in-depth review, we identify significant concerns about an entity's performance and determine that a PIP could result in meaningful cost-saving reforms, the board can vote to require the entity to do a performance improvement plan. Only when there is that board vote does the entity's name become public. So most of this is happening in confidential discussions, and there's a lot that, as we'll discuss, can be done actually before any kind of vote to do a performance improvement plan. To date, there has not been a requirement on any payer or provider to do a formal performance improvement plan, but when one is required, the statute requires that the entity itself propose the PIP with an expected timeline of around 18 months. So the HPC can't require any specific components to be included in the PIP, but the entity is subject to ongoing monitoring and reporting to the HPC. So there's a lot on that slide. I'll pause there in case there are any questions about that kind of process overview before kind of diving into a little more depth. Right. So health status adjusted total medical expense. So this is the metric, as I said, that CHIA is required by statute to use to assess the payers and providers that it will refer to us. The health status adjusted total medical expense measure is a measure of all medical spending for a patient population. So for payers, it's the per member per month spending for hospital services, physician services, pharmaceutical spending, anything that the insurer knows about. The only thing that's really excluded is if somebody goes entirely outside of the insurance system and pays out of pocket and the insurer doesn't even know about it, regardless of who delivers the services to the patients. And it includes the co-payments that the patient may be making. As long as the insurer knows about it, it's included in the data. The only real limitation there is that for that subset of plans where, for example, a self-insured employer might have carved out certain services, so a payer doesn't have the same set of services, information on the same set of services. Those are kind of called partial claims. Those are excluded, obviously, to make sure that the trend is reliable. But by and large, payer TME includes the vast majority of spending. For providers, the health status adjusted TME measure is, again, spending on all medical services for a provider's primary care patients. And so, again, only primary care groups are included in this process. It holds primary care providers accountable, though, for all of the spending. So if your primary care patient goes to a hospital, that spending at the hospital is attributed back to the primary care group. And so hospitals are being held accountable, but in kind of a roundabout way, where they may be held accountable through an affiliated primary care group insofar as spending at that hospital may affect the overall spending for their primary care group. That said, many of our hospitals see patients from many different primary care groups, not just their own. In fact, among the largest provider groups, the majority of patients, the majority of discharges are coming from primary care groups that aren't actually affiliated with the hospital. Then the other key limitation on the provider side is that only data for insurance products that require the designation of a PCP, so really HMO products, are used for this process, obviously trying to make sure that providers know who they're being held accountable for. Then, obviously, it's called health status adjusted TME. It is, in fact, health status adjusted. So this means that the health status adjusted TME measure is not real dollar spending. Rather, growth in health status adjusted TME is a function both of changes in the overall spending, but also the health status or the risk score for the patient population. And I want to note that health status adjustment is very important. It's an important tool used to discourage things like cherry picking. You don't want to disadvantage, for example, a provider who has a sicker patient population. But there are also some challenges with health status adjustment, and you saw some of those on the earlier slides. Health status adjustment can not only reflect changes in demographics like aging and changes in disease burden, but it can also reflect changes in coding. And so we've seen an increase in coding diagnoses as having a higher level of complexity over time, more so than what we would expect based on other sources of data about disease burden and demographic changes. And we see that in the health status adjusted TME measure as well. So as you see on this slide, since 2013, across the major health insurance networks in Massachusetts, total commercial spending increased by about 16% in terms of real dollars. But health status adjusted spending only increased by 4.4%. So effectively 11.3% of the real dollar spending increase was attributed to changes in patient health status or risk. And so it was essentially backed out of the measure that's used to analyze payer and provider performance relative to the benchmark. And I'll note that this trend is showing the overall commercial spending market, but when you look at individual plans and providers, you see this trend as well. Which really brings us to our next slide, which is summarizing some of the key themes that we've seen in the PIPS process to date. So as noted in the top row here, one of the main themes that we've seen in the PIPS process is that the exclusive reliance on health status adjusted spending increases for referral means that many entities with real dollar spending increases aren't being referred into the HPC review process at all. So this may also not impact all entities equally. So some entities that may have more resources to invest in EHRs or coding integrity initiatives may see a greater rise in risk scores than a similar provider or payer who doesn't have those same resources. Another main theme that we've seen is that pharmaceutical spending continues to be a real driver in our market. So you saw on David Auerbach's slides that 3.7 and 3.6% of spending recently has been due to pharmaceuticals. That number can be much higher in a given year for an individual plan or provider. We've seen some plans or providers spike in excess of 20% in a given year. And the timing of those spikes can depend on all sorts of new things: when new drugs entered the market, formulary changes, contract changes with the pharmacy benefit manager, and a number of other factors. So our kind of robust review process allows us to kind of analyze what is the driver, why was there a 20% spike in this year, and what happened in the neighboring years. And then the final theme here, I want to remind everyone that the benchmark is not a cap on rate increases, but a limit on total spending. That said, we've frequently seen in this process that payers and providers are negotiating rate increases that leave relatively little room for spending increases due to other factors: changes in utilization, changes in mix. Certainly in a world in which we could have increased utilization, there are real concerns about the state's ability to meet the benchmark if rate increases are consistently as high as they have been. We've seen a number of other kind of, I would say, more minor things, but still important to note. So one of the things I noted was that we've seen kind of one-time spikes in pharmaceutical spending. We see spikes from a number of different factors. Certainly, just as we were talking about overall spending and what drove the increases in a few previous years, when you look at individual payers and providers, there too we see that a few high-cost outliers could drive spending growth in a given year or something like that. Where payers and providers are being referred to us based on spending in an individual contract or an individual book of business, the majority that are being referred to us are actually being referred on the basis of just one contract, for example, for a provider. So we estimate about 72% of the referrals to us on the provider side have been for a single contract. And so again, kind of emphasizes why it's important to look across multiple years, multiple contracts, to really see, is this being driven by some kind of one-time factor, or is this being driven by something that's really cause for concern? So I noted up top that we have not yet required a performance improvement plan of any payer or provider. That said, I think it's important to note that this is really a very important tool to hold individual entities accountable. So the process that we do here at the HPC is quite in-depth and rigorous, and we generally haul in a number of payers and providers to explain their performance in detail. That oversight really gives them an incentive to limit their spending growth, even in the absence of a formal requirement to do a performance improvement plan. And we have had entities make commitments to us even outside of requiring to do a formal improvement plan to contain their costs in certain ways. Also, the PIPS process has really allowed us to gain significant insight into the market. It's actually allowed us to improve the data that's being submitted to the state, too. In a few cases, we've noticed that there are actual data errors where as part of our rigorous process, we're able to identify those and require resubmission of data. That said, there are also some real limitations to the process that if we want to ensure that the state can meet the benchmark in the future, will be important to address. So as I noted up top, the scope of referable entities is really limited to primary care provider groups on the provider side. It excludes other important entities who we know are major drivers of spending. The referral criteria are also, as I said, based exclusively on changes in health status adjusted TME. And this really kind of has two issues with it. One is that entities who may really have a significant increase in real dollar spending, but who risk scores may have gone up for, they may not be referred to us at all. And that's actually a very large group of entities who aren't being referred into the process. The statute also requires that CHIA look at the increase in health status adjusted TME, which means that they're not looking at the baseline level of spending for an organization. Obviously, there are factors that could mean that a spending increase would be more or less impactful for the state's ability to meet the healthcare cost growth benchmark. You could imagine that an entity that is very large, has a lot of patients or a lot of members with a high level of spending could be more impactful on overall state spending with a lower rate of increase than a smaller organization that had a smaller baseline spending level. Finally, I just want to emphasize that the HPC cannot require a PIP. When we do require one, we can't require a PIP to include any specific goals or strategies, and that the ability to enforce the PIP may also be limited by relatively small penalties, $500,000 for noncompliance. So given that, the cost trends report this year did include some recommendations to enhance the accountability under the benchmark, as you see summarized here. Really, this is meant to ensure that, in particular, those entities whose contribution to spending growth in the state are able to be reviewed, referred to the HPC, and held accountable for their spending performance, and that the HPC and the state has the tools to really ensure that individual payers and providers are held accountable in a meaningful way.
Thank you, Kate. So wanted to be able to kind of give this overview of the key accountability measure for the benchmark, but also to highlight that we do think that some additional statutory changes may be warranted to strengthen this process and to provide a little bit more flexibility based on the lessons learned, and really happy to work with the joint committee in more detail on what that exactly may mean. We have one final section here that we'll go through very quickly, and then be able to take more questions and move on to Zach Cooper. But I do want to bring this back to why do healthcare cost growth matter? Why does this matter for the families and individuals in the Commonwealth? Why are we all collectively working towards this goal? And part of that reason is that even despite the recent progress, there are real challenges that people are facing. And so for just a few more slides, I'll turn it back over to David to just really highlight some of those pressures that individuals and families face in particular.
Great, thank you. Just a few more slides. This one shows very simply from 2000 to 2018, the trend in family health insurance premiums on average. And you can see that it has tripled from about $7,000 per year to over $21,000 per year. And this is the total premium, including the employee portion and the employer portion. If you compile some of the overall growth rates from 2005 to 2018, that's 91% growth. Deductibles over that time grew more than 400%, from $400 to $2,200. And at the same time, median family income grew 42%, much slower. And continuing on that theme of premium growth versus income growth, this is showing those growth rate trends since 2008. You can see in the blue on the top, that's year after year growth in premiums and cost sharing. It's included there too. And you can see the red is growth in family income. You can see from 2008 to around 2012, premiums and cost sharing, and this is in the employer market, were growing much faster than income growth. And that is partly what led to the creation of Chapter 224. And you can see in the years after that, it flipped. And income growth was growing faster. Income is growing faster than premiums and cost sharing. But again, in the last couple of years, it has reversed again, where premiums and cost sharing are now growing again faster than income. And taking those 2 years, it results in this phenomenon where, as we've shown before, if you think about income gains between 2016 and 2018 for an average Massachusetts family, about 39 cents of an additional dollar earned went to healthcare. And that's more than the 38 cents that went into people's pockets for everything else. And that's just on average. You can see in particular, some families are burdened even more than that. And this just shows, for example, about a quarter of the state's middle-class families are paying more than a quarter of all of their earnings, more than, in healthcare. And you can see some characteristics of the families in that situation below. Okay.
So finally, would like to just say that we continue to make recommendations to strengthen this process, to be able to encourage the marketplace to be able to hit the benchmark over time. On slide 40, at a topical level, you can see all of the different policy recommendations. I won't go through any of these in detail. They are included in the cost trends report, which has been given to all of the members here. Happy to take questions on any of these topics, but do believe that there is an opportunity, particularly in this legislative session, for important updates and advancements in our healthcare policy landscape that will help us ensure that we can meet the benchmark into the future and really be able to have affordability gains for the residents of the Commonwealth. So look forward to continued partnership with the legislature on what those next steps may be.
Questions, comments from anyone on the panel? Don?
Thanks. Thank you, Vice Chair. I just want to put a stake in the ground or a point on the record on page 30 on the coding intensity pattern, which this committee, his council talked about at our last meeting and have repeatedly talked about. Just to make the obvious more obvious, according to this, it's as if the health status of the people using healthcare in the Commonwealth deteriorated at a rapid rate, starting in 2013, continuing right now in a continuous way. That's what the coding is suggesting, that these are sicker patients. Actually, what the providers would claim is that these have been undercoded in the past, and a correction is occurring in which now we're correctly classifying patients at the level of intensity. I would find that credible if there were a step function in which there was a problem, and the problem were then fixed, but that's not what we're observing. This is a steady and relentless increase in the severity of coding. As a health services researcher myself, I do not understand that. I don't think we understand the phenomenology. I very much doubt it's actually changing health status in the Commonwealth. And in our partnership with the legislature, as we plan ahead for the next year of inquiry, I hope that this becomes a matter of some pretty deep investigation, and then we can talk about what remedies might be appropriate.
Barbara?
Thank you, Mr. Vice Chair. First, I want to echo Dr. Berwick's comments. It's an important, very important issue that we parse out what's really happening here, because it doesn't make sense based on the data, and we cannot allow that to continue in the way that it does. But I think of all the slides that we've looked at today, the two slides that give me the most pause are slides 37 and 38. When we think about what the cost that is borne by the average family, what their income increase has been, and what has happened just with healthcare costs, not to mention food, not to mention housing, not to mention taxes, not to mention anything else. The burden that is piling on families is unsustainable by them. And that's the piece that should drive our passion for finding solutions here. Those two slides are the most powerful two slides, in my opinion, in this deck. Thank you, Mr. Vice Chair.
Thank you. Yes, Representative.
You brought up urgent care centers. Just want to get your opinion on this. You brought up legislation that we could possibly provide to help in this matter, would we save money? Would it be beneficial for us to pass legislation, for instance, that would allow people on Mass Health to be able to use an urgent care center without having first to get a referral from a primary care physician? And also, there's another bill that would allow ambulances to deliver patients directly to them. Would this help people, especially in the groups we just mentioned, and would it help bring down costs?
So I would say we have definitely documented and found that urgent care centers provide services at a much lower cost than the emergency department. I think I'd have to get back to you on the specific question around the Mass Health referral process. And I don't think that we have kind of weighed in on whether ambulances should be able to kind of directly transfer. But I would note that I think they're kind of an important part of the ecosystem, and where we have also made recommendations around mobile integrated health, which is a way of using ambulance services and paramedics to be able to triage patients and perhaps be able to transport them to other appropriate healthcare settings that may not be the emergency department if that's not the level of care that they need. So I think there's some consistency, at least in the thoughts there. I'd have to kind of think a little bit more about the details of the.
No, but just to be clear, the specific things they do, the services they provide are less costly at an urgent care center than compared to, say, an emergency room. Does our data show that? Like, for instance, treatment of a laceration or treatment of cold symptoms or whatever.
Can I just jump in here for 1 second? So
the answer is yes.
It's hard to know for sure. In a lot of parts of the country, for example, Texas has a lot of freestanding EDs and other freestanding urgent care centers. There are two effects. One is that you divert people from emergency departments in hospitals, which is beneficial. The second is that some people who would have gone to a doctor's office now go to an urgent center or a freestanding ED. In areas where there are a lot of them, that's actually raised spending, because you've diverted so many more from the doctor's office into the in-between emergency department that's been more than the increase in spending that has been saved from keeping people out of the sort of big hospital emergency department. So it's just a very tricky thing to try and say exactly what it would mean.
I would also add, I think continuity of care is something that always has to be considered in terms of not just the incident, but what happens around care. And I would also add that I haven't found many urgent care centers that offer any behavioral health, which we know is a real component of healthcare need and cost. So.
And I would just emphasize, I think, important to have a kind of a data foundation of this industry, where they are, if they're connected to healthcare providers or if they're independent, what populations they serve, and what are the prices and costs of those services. So I think part of our recommendation is really about understanding more about all of those different factors.
Other comments, questions? If not, I think we're ready for our presentation. And so let me turn it over to Dr. Cutler to introduce our guest.
Thank you, Mr. Vice Chair. Seems like a good place to start is with a mic check. So let me just check. Zach Cooper, can you hear us and speak so we can make sure we can hear you?
I can hear you and hugely appreciate the invitation.
Well, thank you. So it's my pleasure to introduce to the Commission and the members of the legislature Zach Cooper. Zach is an associate professor of public health and economics at Yale. He is in the medical school, the economics department, and the Center for Economic Policy, social policy at Yale. He's a true Renaissance scholar in that way. He studies enormous number of things, particularly about healthcare. I'll just call attention to two of his studies, which are extremely relevant and have affected the work of the Commission in quite a number of ways. One is on out-of-network billing. That is when you go to the emergency department and the emergency department is in-network, but the physician is not. The emergency physician is not, and so you wind up with enormous bills. And he has been pushing, both calling attention to the problem and pushing the extent of the problem in legislatures throughout the country, including the federal legislators. And second, on the variation in prices for the same service across different institutions and the role of market power in explaining those. And Zach has done terrific work there, which is really quite interesting because he's, by all appearances, approximately 14 years old, and he's been doing work for about 12 years, so he's really been extraordinarily productive. Zach was going to join us in person, but like many universities, Yale has decided both to, in a short period of time, to end in-person classes and begin online classes, but also, more importantly for this purpose, it has asked its faculty not to undertake any non-essential travel. Zach, I don't know about you, but I'm very surprised that economics is considered non-essential. But be that as it may, we are delighted to have you by phone and look forward to your wisdom. So thank you so much for being willing to be with us.
Well, thanks everyone for having me. And thank you to the Joint Committee and to the board. First and foremost, I apologize for not being able to be there in person. David gave the good excuse for me. It turns out all of our classes are going online, so I'm going to sort of view this as a trial run to see how I am at talking virtually. I think as David can attest, like many academic economists, I sort of motivate my lectures with doom and gloom. But sort of before I get there, I just really think it's critical to applaud you guys for the work that you're doing and the work that the Health Policy Commission is doing. It's incredibly important to Massachusetts, but it's also incredibly important for the rest of the country. So I just joined the Connecticut board that's modeled after what you're doing. We're using you guys as the model, and so is the rest of the country. So I think your efforts here aren't going unnoticed, and I think in short, you're doing a tremendous amount of good. What I want to do is really touch on three themes today. In part because I'm over the phone, feel free to interrupt. Like, don't hesitate at all to pause, jump in there, and ask for clarification. The first theme is really, I think, underscoring why we're talking about this issue in the first place. Right? What is the impetus for making health systems more efficient? And as I'll describe, I really do fundamentally think that some of the biggest challenges we're facing as a nation have their genesis in the health system. And addressing this isn't just an issue vis-a-vis healthcare. It's an issue about really the financial health of the country and broader issues about sort of the dignity of folks who are struggling right now in the country. I think the second, I'm going to try to describe my views on what's driving rising healthcare costs. And then third, I'm, with a sort of hearty dose of humility, going to give my views on, in a sense, what we could do and what we should think about from a policy perspective going forward, both in general, but also specifically on out-of-network billing. And I think on this last point, I think one of the overarching themes for me is if there is a secret for addressing healthcare costs, either Massachusetts or the country, in a sense, there isn't a secret. I think we are going to reduce healthcare costs in a sense through radical incrementalism. And I think that's just basically having very good people looking at very good data and addressing this sector by sector and step by step. I don't think there's some silver bullet out there, some lever that we can pull that's going to rationalize the entire system. So if we can just jump to the next slide. I know that I don't have a clicker. Thanks. So yeah, I think I started motivating my talks in public forums with a slide, something like this, because I think it's actually tremendously important to basically say, look, median household income in Massachusetts is about $77,000, the 25th percentile, 40,000. And we're in a universe at present where the average price of employer-sponsored coverage for a family is $21,000, $22,000, greater than the cost of a new Toyota Corolla. I think we need to have insurance mandates to address adverse selection, but that puts us in a position where we're asking many, indeed most families, to buy a new Toyota's Corolla's worth of insurance every year. And whether or not they're paying their premiums directly or it's being paid in part by their employer, it's coming out of their wages one way or another. And I think one of the things that's sort of omnipresent in my mind is that in many of these sorts of public forums, the folks speaking, the folks in the audience, the folks on the panels, in a sense, don't represent the median household. And I just think it's tremendously important to sort of remind ourselves that in many ways the median family in the country and in the state is struggling and under tremendous pressure. And that sort of by ignoring that, we've gotten to a place where a lot of folks are just tremendously frustrated. And I think also worth pointing out is the average American doesn't have $400 liquidity day to day. So I think then the question is, well, why healthcare costs? Why do we want to reduce them? And I actually don't think necessarily that reducing them is the goal. I think the goal is really to make the system more efficient. And as David and others have really pointed out, we know pretty clearly that our system is not hugely productive. And the big concern for me is really the opportunity cost of our spending on healthcare in this country. That is, what spending are we foregoing because we are spending so much on healthcare? And we can actually jump to the next slide, which uses data from Massachusetts to, I think, drive this point home. There's been a strand of work that has said, hey, look, other countries spend less than us, or excuse me, dramatically more than us on social care. We spend more on healthcare, and they conclude that one of the solutions to address healthcare costs is basically to ratchet up state social care spend. I think that data is accurate. I think the conclusions are not. In fact, I actually think the causal relationship goes in the other direction. And I think right now is as good a time as any to sort of highlight what happens when healthcare costs account for a large and growing share of state and federal budgets. And Massachusetts is the perfect example in the 2000s, where the state's healthcare costs increased by about 60%. And states have a different ability than the federal government, where you can't run deficits. And so you're basically faced with either cutting services or raising taxes. And so during this period where there was a tremendous growth in healthcare costs, what did we see? We saw a near 40% reduction in spending on public health, 33% reduction on mental health. We can go all the way down the line to a 50% reduction in local aid. And so I think this is really the causal relationship. That is, when healthcare spending goes up, it limits our ability to spend outside of the health system on things that are tremendously important, whether that's infrastructure, whether that's aid to local communities, whether that's, in this case, public health investment that helps in pandemics. And realistically, I think businesses are facing the same pressure, both across states but also across countries. When a company that's located in Massachusetts has to spend more per employee on healthcare costs than, say, an employee in another state in the South, they then have to find that cost somewhere else in their production process. Whether that's hiring fewer people, raising the price of their goods, or what have you. We can jump to the next slide, and I think what's sort of quite distressing for me, this is the sort of doom and gloom portion of the talk, is really that families face that same pressure. And for them, it isn't an abstraction. And what you see broadly is income gains in the last 18 years have been about 86%. They've gone up faster than price growth. So at baseline, absent what's happened in the healthcare system, folks actually would be doing pretty well. But the challenge is that the growth in healthcare costs have been such that what would have ordinarily been a very, very good feeling has in a sense been eaten by the healthcare system. Right? So we've in a sense got a healthcare system that's acting as a tapeworm, eating the sort of progress that's being made in the economy. And I think in some ways, if the healthcare system were wildly productive, we'd be okay with that. But in the face of evidence that it's not, I think we need to lean forward. And we need to say, look, part of the reason the average person, either in Massachusetts or in the country, is really feeling tremendous pressure is in part that the gains that they've made, the increases in wages from longer hours in many instances, have actually gotten fed back into a healthcare system. And in some ways gotten redistributed from workers outside the health sector into folks working in our healthcare system. And if we jump to the next slide, the folks before me highlighted this, right? Insurance premiums in the Commonwealth Fund that are among the highest in the country. But I think what's important to point out here is this is not a uniquely Massachusetts issue. This is a challenge I think that all of us are going to face. And if we jump to the next slide, it's basically highlighting what the average total contribution that the employed individual is making, both in insurance premiums and in out-of-pocket costs. But I think what's critical here, as I think certainly David and others in the room can note, is this number, right, this $400 to $600 per year, actually masks pretty stunning variation across people. There's really a right tail of individuals who are spending a fairly staggering amount each year. And I think that's compounded by, in a sense, a system where you can do the right thing and be exposed to hugely high costs. And the example for me is a friend last week, actually, in New Haven, who was hit by a car that ran a red light. Her out-of-pocket costs at the end of the day are going to be tremendous, and that's above and beyond the cost that she's going to accrue from childcare, from her spouse having to take time off work. And I think the question for all of us is, how do we provide financial security? Right? How do we provide a system which, in addition to offering extraordinary medical care, which our system does, how do we stop it from really putting tremendous financial pressure on residents? And how do we sort of abstract away from the folks in this room to say, look, for most folks out there, in some sense, the financial pain they feel from engaging with the system is absolutely tremendous. So we can jump to the next slide, which I think sort of gets into what's driving healthcare costs. So healthcare, like anything else, is largely a function of price times quantity, right? The quantity of what's provided times the price of each sort of widget produced. I think the challenge in healthcare is it's easy to overlook the complexity of what's inside quantity and simply say, look, it's only prices. I do think prices are really the proximate driver of healthcare spending growth. But I think one of the things we have to look at, which some of the folks actually already alluded to, was what we really mean by quantity. And I think there's sort of three aspects of it. One is really this mix of services, and I think of that as sort of inpatient versus outpatient care, physical therapy versus surgery. I think part of that is higher severity coding that we're seeing over time. I won't be hugely subtle about it. I think it's a fairly deliberate exercise, and I think it's one we, in a sense, have a coding arms race between payers and providers. I'm not quite sure who the beneficiary is. I can certainly say that all of us, as in a sense, the collective payers of healthcare, are really the ones footing the bill for that. I think the second is really about the technology that's used within a case. And so, for example, part of the growth in prices, for example, for hip replacement, reflects the price growth itself, right? Literally consolidation, prices going up. But it also reflects changes in the way we deliver care. And so, for example, there could be negative pressure suits being used by surgeons, and some of that's going to show up in price measures. I think the third is just literally the raw count of the number of widgets that are getting produced. And we can jump to the next slide, which shows the distribution of spending across different parts of the system. And again, feel free to interrupt anybody. I'm not there, so you can't raise your hand. I think part of the reason we're talking about hospitals is because, in a sense, that's where the money is. That's the largest chunk. But I think what we really need to do, and I think what I'd encourage the Health Policy Commission to do, is basically go sector by sector and differentiate between price and these three aspects of quantity in each of these bins and say, look, in how can we intervene? How can we help in any of these areas, either on the price or the quantity side? And I think one of the things we know from looking at other states, Maryland's a classic example, we have to do more than just simply batter prices or fix prices. And I think it's hugely important to look at price and to think of different ways, and I'll allude to it, we could intervene on the price side. I think that, first being very, very proactive on antitrust enforcement and being vigilant, knowing what the evidence suggests on mergers, both horizontal and vertical transactions. I think it's thinking a lot about how we can enforce site-neutral billing. I think finally it's thinking about price transparency. But in my view, the beneficiaries or the users of price transparency tools actually shouldn't be the patients themselves. It actually really should be providers, so that they're aware of the options available to their patients and can help them say, hey, look, an MRI at this $200 or $500 facility really does look the same as this MRI at a $3,000 facility. I think that's in some ways a choice that patients themselves can't make. They can only really make that with the help of physicians. We can actually sort of jump ahead 2 slides because I think David went over the next slide. So, I think then the question is what to do. I'm working on a project, a sort of nominally at this juncture called the 1% Healthcare Reform Project. Everyone tells me the title is dreadful, so we're trying to come up with a better name for it. If anybody out there actually knows a better name, feel free to email me. And the genesis of the project was that, like many academic economists, I basically spent a lot of time trying to get data or try to get firms to do randomized trials. And I went to a large firm, tried to get them to do an RCT, and I was describing an intervention that I thought would reduce healthcare costs at that company by about 1%. And the CEO said, I don't want to do things that are going to reduce healthcare costs by 1%. I want to do things that are going to reduce healthcare costs by 15%. And my immediate reaction is, in a sense, we don't know, and there probably aren't single interventions that are going to reduce healthcare costs by 15%, except those that have massive trade-offs. Right? The CEO could stop funding drug care or drugs or hospital care, but obviously that's not something we can do. In fact, all the changes that we're thinking about are really going to come through the accumulation of fairly small, discrete improvements, which then done in tandem collectively add up to large change. And so my view, both for states and the federal government and for firms, is that in part the way we want to think about healthcare costs is how do we get the best data on the problems that we can find? Can we then develop solutions to those individual problems, implement them quickly, and then move to the next one? And for me, that requires a really good staff, really good data, and then in a sense, the dynamism and freedom to intervene where appropriate, and understand that that's going to be, in a sense, a perpetual project. So we can actually jump to the next slide. So David's part of this group, and what we've done, this is the slide that should say health policy is whack-a-mole. Yeah, there we go. What it is, I reached out to the folks that I thought were really the 10 leading health economists in the country. And I asked them, in a sense, what from their research could lead to a policy intervention which would reduce costs, but by and large not have any huge negative effects, where the trade-offs are quite limited. And I think what we know from our research is we're actually not great at measuring huge changes. But I think what we've gotten very, very good at is finding individual sources of inefficiency and being able to positively say what we do to tamp them out. And we ended up coming up with 15 proposals. I've put up a couple here that I think relate to things that you have or could do in Massachusetts where there's actually tremendous evidence base. And I think these, for me, are examples actually of how we begin to really make a difference. So the first is organ donation. It turns out that transplanting organs is actually incredibly cost efficient. The Medicare program, certainly private payers, save well north of $200,000 per transplant, in part because it gets folks off of dialysis, which costs a tremendous amount over time. Now, how do we encourage it? Right? If we want to really take a huge whack at healthcare costs, it's going to be doing something like that. Preferred pharmacy network and the flexibility to modulate formularies in general can have tremendous effects. Some of the work by Jason Avlock and John Gruber about how we structure choices for individuals in health insurance exchanges. We know that people are really struggling to choose insurance products. If we give them nudges, if we change defaults, we can actually make a pretty remarkable difference. We can think about some of the work that you've done that Lee Mordafney's measured about banning prescription copay coupons, efforts to promote antitrust enforcement, which leads me to the surprise billing work that I've done with my colleague Fiona Scott Morton. We can actually jump to the next slide. Actually, the surprise billing ends up being a really good example of what we're trying to refer to as the sort of 1% problem. And I think it's a good example both of the problem and that there are solutions, and in a sense what I believe the policymaking process going forward has to look like. So I think what I find always sort of shocking is this idea that physicians don't necessarily participate in the same networks where they work. So for us as patients, it's possible to go to an in-network hospital, but get treated by an out-of-network physician because those physicians and those hospitals literally engage in separate negotiations. And so you end up in this universe where a responsible individual in an emergency seeks out care in an in-network hospital, gets treated by an out-of-network physician, and then can be subject to an enormous bill. And I think to add insult to injury, it's a bill that comes after the patient did the right thing. And I think one of the subtle but hugely important points is that when physicians can bill out of network but not be chosen and not be avoided by patients, it really changes the way they negotiate their prices. And in fact, you can see groups of physicians, anesthesiologists, radiologists, pathologists, emergency room physicians, who in part because of this idiosyncrasy in our healthcare system negotiate differently, end up having prices that are significantly higher than other physicians who can't be avoided, or excuse me, who can be avoided, who get chosen by patients. And I think what we're going to show you in what comes next is it turns out most doctors are doing the right thing and are in network. But there are small patches of hospitals that have no in-network physicians where the physician staff and companies are making a very, very deliberate choice. And we can jump to the next slide. So the first thing that jumped out at me when I started doing this work was it turned out that out-of-network billing was actually quite common. That if we looked at emergency room care in the U.S., broadly 1 in 5 patients who go to an in-network hospital in an emergency gets treated by an out-of-network emergency physician. We see rates for out-of-network anesthesiologists at about 12%, out-of-network radiologists at about 6%, and out-of-network assistant surgeons at about 11%. That was just way higher than I was expecting. And if this thing was 1 in every 1,000 patients, the solution is in a sense a GoFundMe page. But when we're really seeing 20 to 25% of patients getting treated by out-of-network providers, when there's really no scope for them to avoid out-of-network providers, I think it suggests that there needs to be a systemic policy fix. And what we show in this paper is, take the example of emergency room physicians, whose orthopods on average are getting 180% of Medicare, and internists are getting about 150% of Medicare in our data. The average in-network ED physician was getting 266% of Medicare. She had charges of 637% of Medicare. There's both the problem of these out-of-network bills, but then there literally is the cost that all of us are paying in the form of higher premiums from this market failure. And if we jump to the next slide, this is basically showing across the U.S. And so I should say that you do see out-of-network billing in Massachusetts. It's not dissimilar from the levels of out-of-network billing you would see in other states. What we've shown here is, I actually think a very striking figure, which is basically the distribution of out-of-network prevalence across hospitals in the U.S. And what you see is actually that most hospitals, by and large, actually have no out-of-network doctors. But they're actually doing a really good job at moving folks in-network. But there's a chunk who literally have no in-network physicians. And we tried to see who is in this chunk, and it turned out it was predominantly for-profit hospitals. And it was hospitals that outsourced their emergency room care to one of two large physician staffing companies, one called M-Care and one called Teen Health. The last time we checked, there actually were 4 M-Care staffed hospitals in Massachusetts. So this is something that's occurring everywhere. And if you jump to the next slide, what you see is, in a sense, the business model of this firm, which is that they go into hospitals. What this is showing is the out-of-network prevalence at hospitals where M-Care entered from 12 months before their entry until 12 months after. We've shaded, there's a little noise. We struggle a little bit to get the precise entry date, so that's going to be the gray shaded area. But what you broadly see is that hospitals that previously had very, very low out-of-network incidents had M-Care enter, and by 6 months after their entry, had out-of-network prevalence at near 100%. And there are a couple instances where we actually see M-Care exit, and what you see is the hospital get transformed from having no in-network physicians to going back to looking like every other hospital in the U.S., which is having almost everyone covered in-network. So this is a big problem. I think this, for me, highlights, in a sense, the frustration the average American has with politics in our healthcare system, which is the debate about this basically pits doctors who are doing pretty well with insurance companies who are doing pretty well, and there's gridlock. Nothing gets done, but the person who's getting crushed is the sort of average person who often doesn't have a seat at the table. The good news for me, though, is that this is fixable. So if we jump to the next slide, actually, this is tremendously important. Yeah, I think the question is, like, why does a hospital allow out-of-network billing to exist? The answer is they make money from it. What we see, for example, is that M-Care was offering hospitals a pretty significant reduction in their subsidies. That was about $200,000 a year. They were increasing the activity, the number of tests they ordered at hospitals that raised hospital bills by about $1.7 million per year. They were, in many instances, sharing profits with hospitals. All told, we estimate that this is going to raise hospital profits by about $2 million a year, when the average hospital is making $12 million in profits. Right? So this can actually be incredibly lucrative. We can jump to the next slide. The good news here is this is fixable. And we've seen in New York and we've seen in California that legislators have actually really been able to intervene in ways that have improved things for consumers and lowered healthcare costs. And so I think there is scope for action on this, just like there is on a range of other issues. So when it comes to out-of-network billing, there are, in a sense, 2 problems we need to solve. The first one's quite easy. The first one's basically saying, hey, look, if you're a patient who goes to an in-network hospital, does the right thing, and accidentally sees an out-of-network physician who you didn't choose, we're not going to allow you to get crushed and balance billed. We're just going to create what's called a hold harmless provision. I think the harder question is how do you settle the negotiation between insurers and physicians over out-of-network bills. There are different options. One of the federal proposals right now is that arbitration. You could regulate it. We have a proposal that basically says, hey, look, we're just going to ask hospitals to sell a package of care. that includes physician and facility services. The idea being that I, as a patient, don't choose when I choose an emergency room, I'm choosing both a doctor and a hospital at the same time, so that's what we should ask hospitals to sell. There are virtues and vices to each of these approaches, and if the time comes, I'm happy to talk through each of those. But I actually think what's critical is that any of these options, as long as they're well designed, are actually considerably better than the status quo. And we looked at what happened in New York, which introduced arbitration, and we can jump to the next slide. And what you see is the out-of-network prevalence in New York went down by 12.8 percentage points, about 88%. Right? So broadly, it shifted almost every provider in an emergency room in-network. And it lowered in-network payments that were previously artificially high because of this sort of idiosyncrasy in how ED physicians billed. It lowered their in-network payments by about 15%. That then gets passed on to consumers in the form of lower insurance premiums. The reason I highlight this is both because I think this is a first order issue, but for me, and I'm happy to think about whether or not I'm thinking about it the right way, but for me, this is an example of how we have to think about policymaking. That there are, in this case, we estimate that nationally addressing out-of-network billing would reduce healthcare costs by about 3 to 5%. The Congressional Budget Office has estimated some of the most conservative proposals out there would lower premiums by about 1%. This, for me, is how we're going to reduce healthcare costs. It's going to be addressing things like out-of-network billing, then addressing drug copay coupons, increasing organ donations, going down the line, and then being perpetually vigilant in addressing the next iteration of out-of-network billing. I think to do that, you need a health policy commission like you have, like we're trying to build after a model after you guys in Connecticut, and then it's about sort of collecting data, knowing what's happening, and having a dynamic legislature that understands that it just isn't going to be one shot. It's going to be sort of perpetual tinkering that ultimately is what's going to help folks in the long term. So that's the sort of talk, and then happy to answer any questions that anybody has.
Thank you, Dr. Cooper. Questions for Dr. Cooper?
Can I want to start off with one, Zach. This is David. Thank you for the presentation. It was excellent. You gave a couple of items on your list of kind of things you think that Massachusetts should look at. I was wondering if you could give us a little more detail about, like, where do you think we should start off? You know, like out-of-network billing is clearly one that we ought to look at. What else should be high on our agenda as you look at Massachusetts? Zach, are you still there? I thought I was being nice. You should see me ask other questions. They're not nearly as nice.
Ellie, will you just type what you want? The question? Can you
Is he?
Absolutely. So I think there are a couple areas. I think organ donation for me is a shockingly efficient way or effective way to lower healthcare costs. So I think that would be one of the first things that I looked at. I think we need to start looking at particular market friction on the drug side. I think orphan drugs and the way we pay for orphan drugs that are off patent is another where there's just this sort of obvious market failure. I think we need to think a lot about providers' prices. I think in that case, site-neutral billing is the first sort of obvious stop for where I'd look. And then after that, what I'd say is, I think this is where the data work you're doing can be so tremendously important, where you can, are folks hearing me? I'm just getting a message in the back.
Yes.
Yes.
sure folks can still hear me.
Yep.
I'll keep going. So I think providers' prices, and then I think it's using data to navigate around.
Commissioner Berwick, did you?
Yeah, Zach, can you hear me? This is Don Berwick.
Might be a delay.
Well, maybe we can type the question. With respect to the severity coding migration that we've noticed here and you commented on, what recommendations might you have for starting on that?
Thanks, Jonathan.
Yep, I can hear you, Don.
Okay.
Thanks. There's a delay, Zach.
Severity coding migration. So I look at who the providers are who are doing the shift in code, how widespread it is, and then I would start, I think, looking in more detail and having more conversations in detail with providers to try to get explanations for it. I think one of the challenging things with seeing shifts of coding of that type is sort of inferring whether it's a deliberate act by providers or is a response to something that's sort of happening organically. I think one of the things we saw, for example, when MCare entered a hospital was an almost immediate switch in the incidence of using the highest severity observation codes. I think when you see switches that are happening overnight like that, it tends to be suggestive that it's probably something that the provider is doing and not something that's happening in the patient population.
Great. Other questions for Dr. Cooper? None? Zach, thank you very much. Very enlightened presentation. We really appreciate your time. Okay. I think we're at the point of our hearing to open it up for public testimony. For those participating by phone, I will call on you, but please be sure to talk clearly and loudly into the phone. You are currently on mute, but will be unmuted for your testimony. As mentioned earlier,
Thanks, everybody. Sorry for the delay.
All right, thanks, Zach. As I mentioned earlier, the public is also invited to submit written testimony, which will be posted to the HBC website, and the deadline for submission of written testimony is Friday, March 27th at the close of business. I will now first ask those who are present to testify first. I would ask that you limit your remarks to 4 minutes.
Marty, can you hear me?
I can. Stuart?
Your voice, there's no voice coming in from the...
Yeah, same here. I can hear the speaker, but I cannot hear anybody at 50 Milk Street.
Okay. We think there's a delay. Are you getting us on a delay, Stuart?
Marty, we can't hear you.
Can you hear me?
Yes.
No?
Yeah. I can hear
Yeah. But
Oh, is he?
we can't hear them.
Yeah.
No, that's.
Yeah, something happened.
Can you hear us now, Stuart?
I don't think they can hear us either.
Just don't say anything.
I don't know. Your answers are very good. This is Stuart. Hi, how are you, Zach?
So much for
Yes.
Stuart? So much for technology.
We can't hear you, Ellie. We can't hear the group.
Just bear with us one moment.
I'll send David an email. I don't have his text number, but I'll send him an email to let him know.
Zach, I just sent it. They know it.
Okay. No, this is Ron.
states
And-
just have a conversation with Zach.
Yeah.
Let's just continue.
Oh, you know what? It keeps automatically. Stuart, can you hear us?
We put him on mute temporarily just to try and troubleshoot.
All right.
The healthcare cost growth benchmark for calendar year 2021. Again, my name is Alex Sheff, and I'm co-director of policy and government relations at Healthcare for All. Healthcare costs continue to be a leading concern in the Commonwealth, and that's why we recommend that the Health Policy Commission continue to set the benchmark for calendar year 2021 at 3.1%. We also hope that the HPC considers ways to ensure consumer costs do not exceed the benchmark across the market. High levels of health insurance coverage in Massachusetts do not guarantee access to care or the affordability of care. For the past several years, the state has been successful in keeping healthcare cost growth under the benchmark, but the same cannot be said for the costs that consumers face. Instead, consumers have seen out-of-pocket costs and premiums grow twice as fast as overall healthcare costs, straining family budgets and putting care out of reach for many. We hear the concern daily on our helpline that takes 20,000 calls a year. One call was from a woman worried she couldn't continue to afford her $700 a month premium and the $180 she pays out of pocket for her medication. Another woman was pregnant and concerned about the bills she would have to pay before she hit her high deductible on her employer plan. And data confirms what we hear from consumers. And so CHIA's Massachusetts Health Insurance Reform Survey found that in 2017, 25% of Massachusetts respondents reported that they went without needed medical or dental care due to cost, despite the fact that 2/3 of those individuals had insurance at the time. The CHIA 2019 annual report sheds light on why families across the state continue to struggle to access affordable care. So member cost sharing for those with private commercial insurance rose 5.6% in 2018, after growing 6.7% in 2017, and with unsubsidized individual purchasers paying the most out of pocket, followed by those with small group coverage. In addition, the CHIA report found significant premium increases across the commercial market, 5.6% in 2018, 4.8% in 2017. The cost increases are also, as we've heard, based off of an already expensive starting point. So a 2019 analysis by the Commonwealth Fund found that Massachusetts had the highest employee premium contribution in the country, and I think at the time the 5th highest overall premium for employer-sponsored insurance. The increases also far outpace overall system growth, as we've heard, as well as salary growth and regional inflation. So put simply, consumers are paying more of every dollar they earn towards health care and are shouldering more than their share of the burden of increasing system costs. Consumer cost increases, while greater than system cost growth, are nonetheless a response to underlying cost drivers. And according to the CHIA 2019 annual report, the largest single driver of cost growth this past year was prescription drugs, accounting for 26% of growth, 14% net of rebates. However, hospital, inpatient, and outpatient costs have also been a significant driver, accounting for a combined 40% of the overall cost growth. And all three categories grew faster than overall growth. This is not even across market segments. We know commercial plans experience the fastest growth, with only Mass Health coming in under the benchmark. If it wasn't for Mass Health, the state would not have met the benchmark this last year. And that helps explain why many consumers continually are squeezed by higher premiums and out-of-pocket costs, even as the state continues to meet the benchmark. Tackling the growing challenge of healthcare affordability in the state will require both a direct approach to rising premiums and out-of-pocket costs, as well as efforts to address the underlying cost drivers. HCFA would like to take a moment to highlight several policy recommendations outlined in the HPC Cost Trends Report that we think are critical for protecting consumers and ensuring access to affordable care. First, we support the HPC's recommendation to extend the Commission's review of drug costs to the private market. The transparency and accountability process for Mass Health that was enacted in the state budget last year, that was referred to, has been tremendously successful, producing $18 million in net savings to the state since just November 2019. And given that success, we think it should be applied to help the 3 out of 5 residents who have private health insurance. We also support policy recommendations to protect consumers from surprise out-of-network billing, as we've just heard a lot about, invest in primary and behavioral health care, reduce administrative complexity, and focus on healthcare disparities. Finally, we support and want to highlight the recommendation to strengthen the cross-growth benchmark through improvements to the Performance Improvement Plan, or PIP plan. That could include using new metrics for identifying whether entities should engage in a PIP, looking at the benchmark by more granular market segments, and considering appropriate responses for entities above the benchmark. Most importantly, we urge HPC to consider ways that the benchmark could be applied to directly protect consumers from growing out-of-pocket costs and premiums. So thank you again, and I'm happy to answer any questions or go into detail on any of those points.
Great. Any questions? If not, Alex, thank you very much.
Absolutely.
Next, we have Mental Health Legal Advisors Committee, Susan Fendel, Senior Attorney.
Thank you. Mental Health Legal Advisors Committee is an agency under the Supreme Judicial Court, and we provide advice and representation to persons throughout the Commonwealth on mental health legal matters. I'm going to address 3 items, primarily shifting costs to patients and insureds, integration of care and its relationship to the potential exasperation of not exasperation, its potential increase of healthcare disparities, and alternatives to problematic financial incentives to providers. All 3 of these have an effect on healthcare costs and are interrelated to each other, and to person-centered care and the quality of care people in the Commonwealth receive. MHLAC opposes an increase in demand-side incentives to consumers, tiering of providers of medication, discounted limited network plans, deductibles for medications and imaging. They are not affordable. They are counterproductive. We all know that people who can't afford medications end up being non-compliant or not getting the medications at all. Deductibles cause people to forego necessary care. Eventually, that will end up in poorer health, which can increase the cost of health care in the Commonwealth. Tiering of providers is faulty. There is not sufficient granularity to ensure quality for each individual, because when the hospitals, for example, are tiered, it looks at a few procedures, and that may not be the procedure the person is going to the hospital for. And so it really is not an adequate way of determining quality. It may determine cost, but not quality for the individual. We know what deductibles can do, and limited networks really hurt continuity of care. For people with mental health issues, continuity of care, the Therapeutic Alliance is the single most important indicator of a favorable outcome. And that's why we're hoping House 907 will pass in the legislature this session. But limited networks make continuity of care very difficult because people change insurers for numerous different reasons, and insurers change their networks constantly. We also think that shifting risk to providers will end up repeating the HMO experience. Care can be cut, and there are not sufficient quality measures to make sure that quality is not also at risk. There are many alternatives to reducing healthcare costs, social determinants of health, and I must admit I disagree with the professor. It is almost impossible to improve somebody's health if they're living on the street. Housing is an imperative means, a very necessary tool to lower healthcare costs in the Commonwealth. And Housing First has been used elsewhere and has reduced healthcare costs significantly. Things like meditation for pain control, I was glad to see the Commission included recovery coaches and peer support in its 2019 recommendations. However, these are not funded well, and these should be funded by insurers, not just the government, because insurers have the potential of reducing their healthcare costs if they contribute to the cost of housing their insureds, making sure there's food adequacy. One of the other difficulties is government spending tends to go to evidence-based care. And I have testified in the past about how evidence-based care is not necessarily very evidence-based. There are conflicts of interests. They can often be based on faulty or very weak information. Reliance on choosing wisely, while they corrected some of the problems with their program, it still doesn't deal with the primary problem that if an alternative is not going to make a corporation money, it is not going to get the same kind of research that other modalities of care will get. So therefore, I ask that the targeted funding the Commission is thinking about go to social determinants, things like exercise, which helps everything, peer respites, meditation, and emotional CPR, which is a means of treating mental health care. Thank you very much.
Thank you, Susan. Any questions? No? Next, we have Michael Rubenstein from Greater Boston Interfaith Organization. Michael.
Good afternoon, Vice Chair Cohen, Director Seltz, Vice Chair Cullinane, legislators, commissioners, and members of the Health Policy Commission staff. My name is Michael Rubenstein. I am co-chair of the Greater Boston Interfaith Organization Healthcare Action Team. The Greater Boston Interfaith Organization, or GBIO, comprises 41 dues-paying institutions representing over 45,000 people in Greater Boston. GBIO is here to voice our support for keeping the health care cost growth benchmark at 3.1%, the lowest level allowed by law. However, Massachusetts residents are still feeling the burden of high healthcare costs. Keeping the cost growth benchmark as low as possible is an important tool to hold healthcare providers and other healthcare organizations accountable to the people they serve. While keeping this benchmark as low as possible, the Health Policy Commission and other state agencies must also take further action to lower costs for residents of the Commonwealth. As the ultimate policy recommendation in the 2019 Cost Trend Report says, healthcare affordability must remain a central focus of the Commonwealth's healthcare agenda. To this end, we urge the Health Policy Commission to develop additional benchmarks and points of leverage to lower costs for Massachusetts residents. We applaud the new regulations developed by Mass Health and the Health Policy Commission to negotiate additional supplemental rebates from drug manufacturers, leading to $43 million in gross savings and $18 million in net savings to the Commonwealth as of February 2020. We urge the legislature to pass prescription drug reform that will allow the Health Policy Commission to incorporate critical information from drug manufacturers into their analyses of healthcare costs, as well as hold pharmaceutical companies accountable for the outrageous costs of specific drugs. We lift up the work of the Health Policy Commission on surprise out-of-network billing, a practice that overwhelms vulnerable Massachusetts residents and which has been discussed extensively today. And we encourage you to continue to focus on the many challenges to delivering affordable mental health and substance use disorder care. With so much mental health and substance use disorder care delivered without the benefit of healthcare insurance coverage, this is another important area where the cost control benchmark fails to reflect the burdens of Massachusetts residents. We finally want to urge legislators to persevere, especially on those reforms where consensus exists. As was mentioned in Professor Cooper's keynote, there are no silver bullets, and the worst outcome would be a repeat of last session's failure to make any reforms on healthcare whatsoever. To date, 542 GBIO members have met with 19 state representatives to push for legislative action and make healthcare more affordable. Despite the current state of emergency caused by the coronavirus, people continue to suffer from ongoing challenges accessing and affording the health care they need. Our stories of losing a parent who couldn't afford their asthma medications, being left untreated for days in an emergency room waiting for a mental health care bed, or deferring rent or food to pay a surprise out-of-network bill, these stories are still happening to people across Massachusetts. The healthcare cost growth benchmark expresses a human value. The cost of healthcare must be limited so that people's health is not determined by their ability to pay. We urge the Health Policy Commission to stand strong in asserting this value as responsible stewards for the well-being of the people of Massachusetts. Thank you very much.
Thank you, Michael.
Thank you.
Any questions for Michael? If not, thank you. And thank you to those who appeared in person. I want to do a check of the technology. Stuart, can you hear us?
He can't.
He can.
No.
We have two online testimony. I'll see if they're available. Liz Leahy, Chief of Staff from the Mass Association of Health Plans. Liz, can you hear me?
She might not be able to hear you, but we are communicating with her electronically to convey to her that she can give her testimony.
She can hear you on the YouTube channel, so let's just wait.
A little delay.
Association of Health Plans. Liz, can you hear me?
I can hear you. Can you hear me?
Yes, but I think that's delayed. Ellie, can you have her just...
Association of Health Plans. Liz, can you hear me?
I can hear you. Can you hear me? Thank you, commissioners, and I apologize for the delay. I think because of the disconnect between us and you, I'll just jump into my testimony, and I'll keep the video up. If your hands are waving frantically, I'll assume that you are hearing me. So thank you so much, commissioners and members of the Healthcare Financing Committee. As was said, this is Liz Leahy. I'm here on behalf of the Massachusetts Association of Health Plans. We represent 17 member health plans that provide coverage to approximately 3 million Massachusetts residents in the commercial market, on the state's health connector, in Mass Health, and for duly eligible individuals. We appreciate the opportunity to provide feedback on modification of the 2021 benchmark. We support maintaining it at 3.1% for 2021, but would like to highlight some findings today that continue to threaten our collective ability to meet the benchmark. Healthcare costs in Massachusetts, as we've seen, are among the highest in the nation and continue to pose a significant challenge for individuals, families, and employers. As we saw in this year's annual report from CHIA, healthcare costs are beginning to grow at an accelerated rate as compared to years past. In 2018, total healthcare expenditures reached $60.9 billion, growing by 3.1% to match the benchmark. With spending growth increasing at a faster rate for the largest service categories than in past years, the cost growth benchmark remains a vital guardrail for monitoring performance in the healthcare sector, setting priorities for addressing costs, and holding the system accountable. And while a lot of great work has been done, there is still much more to do because the very same factors continue to challenge the cost benchmark. Persistent increases in prices, care being delivered at and shifting to high-cost settings, and unprecedented increases in prescription drug costs with little transparency for drug manufacturers. Not only do these factors challenge our collective ability to meet the state's cost growth benchmark, regardless of where it's set, they also contribute significantly to increasing premium costs for individuals, families, and employers. Prescription drug spending continues to outpace costs for all other spending categories. It accounts for 26.4% of increased spending, 16.3% of total healthcare spending, and nearly a quarter of commercial spending. For the past several years, providers and payers have been accountable to the benchmark, subject to performance improvement plan process, providing testimony and data under oath at the cost trends hearings and to the Center for Health Information and Analysis, but pharmaceutical manufacturers have notably been missing. This lack of representation has allowed years of unchecked cost growth for prescription drug manufacturers, threatening our ability to meet the benchmark and bend the cost curve. So that's why MAP and our member plans strongly support the HPC's recommendations in the 2019 Cost Trends Report to increase oversight transparency for the full drug distribution change. Actions to expand the HPC's current authority to review drugs with a financial impact to the commercial market is necessary to truly understand the impact of prescription drug prices on the healthcare market. And equally important is the requirement that drug manufacturers and PBMs be part of the annual cost trends hearing. It's time for the entire system to be held accountable the way provider groups and payers are today. We're also concerned about the continued challenges of provider prices and price variation. Over the past decade, over 30 state reports have examined healthcare costs and key cost drivers in Massachusetts, and each and every report has found that prices charged remain the most significant factor in driving healthcare costs. And this year's cost trend report highlighted some concerning new trends associated with pricing and utilization in the hospital inpatient and outpatient settings. Stakeholders have also identified key cost drivers for employers and consumers that challenge our ability to meet the benchmark, things that the HPC has highlighted in the cost trends hearings, like inappropriate facility fees, inappropriate pricing for urgent care services, unexpected and overblown out-of-network billing by providers. We hope the Commission will continue its focus on these key cost drivers for consumers and seek to understand their impact on the cost benchmark. Premiums and member cost sharing reflects the cost of care. We have to address the underlying cost drivers in order to provide relief to employers and consumers. And finally, I'd be remiss if I didn't mention the impact of unexpected costs on the cost benchmark. Our state, our entire healthcare system is working to address, mitigate, and understand the impact of coronavirus. So we would urge the Commission to keep a close eye on the impact of virus on spending in this year's cost benchmark and the potential impact on healthcare expenditures in future years. Thank you so much.
Thank you, Liz. Also online, we have Gregory DeConcilius from the Massachusetts Association of Ambulatory Surgery Centers. Ellie, are you in touch with Greg? Okay.
Well, hopefully you can hear me. I can't hear anything from you guys, but I'm getting the message here to begin, so I will. Good afternoon, Mr. Chairman and members of the Health Policy Commission and the Healthcare Financing Committee. You may have mentioned it, but my name is Greg DeConcilius. I am president of and here on behalf of the Massachusetts Association of Ambulatory Surgery Centers. I am also a practicing physician assistant and administrator of Boston Outpatient Surgical Suites, a multi-specialty ambulatory surgery center in Waltham. Just a bit on the Massachusetts Association of Ambulatory Surgery Centers, or MAASC. We are the only organization in the Commonwealth of Massachusetts devoted solely to promoting the interests of freestanding ambulatory surgery centers, or ASCs. Member facilities provide care to more than 300,000 patients annually. The MAASC appreciates the opportunity to provide comments to the Health Policy Commission and the Joint Committee on Healthcare Financing as it deliberates a potential adjustment to the state's healthcare cost benchmark. The MAASC encourages retainment of the current benchmark at 3.1%. This figure is below the national rate of healthcare cost growth and will allow the Commonwealth to continue its aggressive efforts to provide even higher value care within a reasonable and consistent cost benchmark. That being said, the MAASC would like to discuss several opportunities to redirect existing resources that will increase cost savings in the area of outpatient care and increase access to high-quality surgical and diagnostic services. The 2019 Cost Trends Report provides an excellent analysis of the outpatient care market. The MAASC would like to see that report dive even deeper into the various providers of outpatient care and corresponding cost implications. For example, Chapter 4 of the report, relative to hospital outpatient spending growth, notes that its focus is on hospital outpatient departments of acute care hospitals and does not include other providers of outpatient surgeries, like freestanding ASCs. We would very much like to see future reports be more comprehensive and allow for comparison of all providers of outpatient surgical services, not just hospital-based or affiliated providers. We believe that such analysis will help shed light on potential cost savings in this arena, especially since Medicare reimburses freestanding ASCs about half of what it reimburses hospital-based or affiliated outpatient providers, even if it's the exact same procedure performed by the exact same surgeon. That's such a key point. In my submitted written testimony, I remark on a few other noteworthy points and policy recommendations that come from the Cost Trends Report and point to the value of freestanding ASCs and its implications for cost savings in the Commonwealth. I'll just note two key takeaway points in the interest of time. The first is that cost savings will not be realized simply by shifting care from inpatient to outpatient. What matters most is where that outpatient care is delivered, or the site of service. This is a fact that the HPC has long noted since its 2015 Cost Trends Report. My second point is regarding competition and the value of freestanding ASCs in reducing costs in the competitive healthcare market. As you have noted, quote, competition from non-hospital settings, end quote, for example, from ASCs, benefits the healthcare system. We all know competition lowers healthcare costs overall. ASC should be embraced as a key solution for lowering healthcare costs in the Commonwealth. And I will say, as we were reminded a few times in earlier presentations, an increasing number of healthcare consumers have high deductible plans and increasing out-of-pocket expenses. We cannot continue to do a disservice to these consumers, as they can be directly impacted by these savings. In conclusion, the MAASC strongly supports the ambulatory care recommendation in the 2019 Cost Trends Report, namely scrutinizing and analyzing ambulatory care delivery, spending, and utilization trends. You know, as I was listening to Professor Cooper's presentation, he mentioned the word opportunity, and that kind of stuck with me. The opportunity for cost savings in outpatient surgical care a continued outlier and noted again by Commissioner Arbeck earlier, the opportunity for cost savings already exists in ASCs. It's just a matter of how we take advantage of this opportunity. We appreciate the opportunity to offer these comments, and we look forward to continuing to work with the Health Policy Commission and the Joint Committee on Healthcare Financing on promoting increased access to high-quality, affordable, outpatient surgical and diagnostic care to all patients in Massachusetts. Thank you.
Thank you, Greg. Just for the record, we have written testimony, either have received or expected from the National Federation of Independent Business, Atrius Health, Lawrence General Hospital, the Conference of Boston Teaching Hospitals, the Association for Behavioral Healthcare, and Blue Cross Blue Shield of Massachusetts. Once again, the deadline for submission of written testimony is Friday, March 27th at 5 o'clock. I want to thank the members of the Healthcare Financing Committee and the HPC Board. I also want to thank Dr. Zach Cooper for his presentation. Any final points by the members or by the legislators? If not, our next meeting is scheduled for April 1st, 2020 here at the HPC offices. David, anything else?
I just want to say thank you again to the Joint Committee. Thank you to those who are here to testify, and thank you for those of you who did testify virtually and remotely, and apologies for the fact that you couldn't hear us. We could hear you, and your testimony is well taken. So I think we're at the conclusion.
All right. No other business. I'll call the meeting adjourned. Thank you.